in cross country. And then she went to some school in College Station for her master's that we'll leave unnamed because I knew there would be one in here. I didn't want to honor y'all with that online. Sorry for you Aggies. She works at our cardiology clinic at San Antonio, and I'll tell you that if you read on your day sheet, she's involved in about everything there is in the world of cardiac and Methodist, running labs and doing everything. But she has been leading the charge in some of the emails that you've received from me regarding the questions you've been asking about what does return from symptomatic COVID exposure mean for our athletes. And so that's really going to kind of be the focus of her today. So far, they've been the only group that we've been able to research and find that are truly offering an intense evaluation for return to sport. And so she'll talk to you guys some about that, give you some options about what their clinic is offering. And as we continue to find others, we will pass that along as well. So without further ado, Kathy, thanks for being here.
Give me 1 second to get you up and running. Because of course, I'm gonna throw this computer away. This is where I need Melissa.
FaceTime her in. Alrighty, well thank you for the introduction. Like Sam said, I'm a certified clinical exercise physiologist. So I'm going to talk about COVID-19 and the athlete's heart today. Couple disclaimers, I am not a doctor or a COVID expert, but I'll do my best to keep it short and sweet and give you guys an introduction on why COVID is important in our athletic populations, and then hopefully have some time for questions at the end. So my goals for today is just to raise awareness of why is it important to have a cardiac evaluation for your athletes, to help athletic trainers and coaches know what to look out for, what are these red flags and warning signs of cardiac complications, and then to give some insight into what you can expect from a cardiac evaluation if it is warranted. It's a little low. Okay, so why is COVID relevant in an athletic population? We always hear who's at risk for COVID, who's at risk for having a bad reaction to COVID. We always hear people that are older, people with heart disease, people with hypertension. We don't really think about our athletes. When we think of our athletes, we think they're kind of immune to everything. They're above getting very sick from this. But we actually have two very important considerations to think about when we're thinking about our athletes in COVID. So we all know athletes are not general population. They have different requirements. Athletes have different sleep requirements, different nutritional requirements. We don't treat them just like your average population. So when it comes to COVID, we have two considerations. The first is called EICR, exercise-induced cardiac remodeling. So this is a good thing. It's the heart adaptations that take place over prolonged athletic training. So the heart muscle gets thicker, it gets stronger, it beats better. We can see different changes on the EKG, that if we saw a 60-year-old with heart failure present with this EKG in the clinic, we'd be worried. However, if we see an athlete present with it, we know it's a normal adaptation. So already with COVID, we have a little bit of difficulty with athletes because it's hard to know what's normal versus abnormal at baseline because of these cardiac adaptations from prolonged exercise training. Also, performance demand. So we demand a lot from these athletes' hearts. During exercise, the cardiac output, so the amount of blood pumped out per minute, increases 5 to 6-fold. So we're really demanding a lot for this from these athletes' hearts. So with COVID and the athletes, we have these two considerations that it's kind of tricky to find abnormalities, but it's very important that we do because we're going to demand so much from these athletes' hearts. So why are we even talking about the heart with COVID? So COVID affects the heart differently than a lot of other viruses. So the SARS-CoV-2 virus, which is responsible for COVID-19, binds to the ACE2 receptor, that stands for angiotensin converting enzyme 2 receptor. And these receptors are really found all over the heart, the lungs, and the whole cardiovascular system. So more so than some other common viruses that we know, this virus really does attack the heart. We can see a compromise in heart function in two ways. So systemic inflammation due to cytokine storms, and then direct viral infiltration. So this is the virus actually getting into the cell of the muscle. This can cause something called myocarditis, which is really going to be the focus of this talk. Another disclaimer, this isn't a scare tactic. Honestly, most of your athletes that have COVID are going to be fine. This is just to raise awareness of myocarditis, what it is, how to look out for it, and then what do we do. So myocarditis, that just means inflammation of the heart muscle. This can be bad for a few reasons. So it reduces the pumping ability of the heart. You can have dysfunction in how the heart pumps, how the heart fills with blood, and this can lead to heart failure. So we probably won't see a lot of heart failure in our athletic populations, but that is the definition of heart failure, a reduced pumping ability of the heart, and we do see this with myocarditis. Secondly, it makes the heart muscle electrically unstable. So you guys know from the athletic training room, you have, I forget what you call it, TENS or TEMS or something. You put it on the bicep, it sends a little electrical signal, it contracts. So that's how the heart works too. It has its own little electrical signal. The electricity triggers the heart to contract. If the muscle is electrically unstable, that's going to cause things like arrhythmias, and that's what's really dangerous with exercise. We don't want our athletes with active acute myocarditis to exercise because they can have a higher risk for these deadly arrhythmias. And third, exercising during an acute phase of myocarditis can actually damage the heart muscle even more. It can increase the amount of virus going into the heart, so the viral infiltration is higher. So we don't want these athletes to start exercising while they have an acute phase of myocarditis. That's why it's important to detect. Okay, so having myocarditis bad, we just went over all of this, but looking for myocarditis is a little controversial. So there's a lot of guidelines that have been put out. None of them are based on long-term data. We don't have any long-term data from COVID. We don't have a lot of data in the athletic population either. So a lot of the guidelines that are out from American College of Cardiology are really just considered expert opinions. Some guidelines put out by different organizations advocate for different level of testing, and there's just controversy in this. That's because of this EICR, so the exercise-induced cardiac remodeling. How do we know if what shows up on a test is a normal adaptation to an athlete, or is this a complication caused by COVID? That's where it really takes a specialist to dive into that a little deeper. We don't have an accepted definition of what clinically relevant myocardial injury is for athletes. Troponin, so one of the tests that we do for myocarditis is a blood test. We look for troponin. Troponin is an enzyme released by the heart when there's a heart attack, heart damage. However, it's also released during exercise. So an athlete who just did a 10-mile run can have high troponin levels 24 to 48 hours. So that makes some of our findings non-specific. EKG findings can be non-specific. It can get expensive. The gold standard way to look for myocarditis is a cardiac MRI. That's that big machine on the bottom left there. We don't want to overdiagnose. We don't want to lead to medical disqualification. And like I said, the data is limited. So that's going to kind of be the theme for the day. The data is very limited. COVID has not been around for a long time. We don't have a lot of data, especially in the athletic population. However, with all the controversy, it is very important to detect it if it is there. So if you guys just Google myocarditis in athletes, you're going to see a slew of articles coming up, all with big, scary titles. So COVID athletes experience heart damage after COVID-19. Ohio State finds heart damage in 15% of college athletes after COVID diagnosis. And then, does anyone know who this is? So if you've been paying attention to the news, this is Keontae Johnson. He's a basketball player for Florida. I think it was the 22nd, it was about a week or two ago, collapsed during a basketball game, ended up having to go to the hospital, was put in a medically induced coma, diagnosed with myocarditis. Turns out he did have COVID a few months ago. There's not a lot of updates yet, so we don't know if the COVID caused myocarditis, but it's just an example of what can happen if myocarditis goes undetected. The Big Ten has reported that nearly a third of their COVID-positive athletes have clinical evidence of myocarditis, and myocarditis already accounted for 7 to 20% of sudden cardiac death in young adults. So it's important to find. However, my disclaimer will be, we don't have MRI data for other viral infections. So is myocarditis this common after the flu? We don't really know. So athletic trainers, what are your roles? So understanding the risks of exercise with myocarditis, if you've totally been ignoring this, then I put a little summary on the bottom there. Knowing the signs and symptoms, so chest pain, increased fatigue, shortness of breath, lack of stamina, and palpitations. 3, to seek evaluation by a cardiologist and get recommended return to play guidelines. And then 4, have an emergency plan. So that's one of the biggest things, making sure everyone's trained in CPR, knowing where your defibrillator is, being able to identify the symptoms of a cardiac problem. So the cardiac evaluation starts off with an initial appointment. This is just a discussion between the athlete and the physician. They'll talk about their history, their family history, the COVID infection severity. Was it asymptomatic? Was it mild? Was it severe? Were they hospitalized? They'll talk about the symptoms that they're still feeling. So back on this page, the symptoms that we're looking out for: chest pain, fatigue, shortness of breath, lack of stamina. They'll talk about the sports demands. So the cardiac requirement for football is different than golf, is different than swimming, is different than cross country, is different than track. So they'll talk about what are we going to be requiring these hearts to do. And then usually they'll do an EKG as well. It's a very simple, cheap, easy, non-invasive test that gives us a good idea of how the heart is looking. Further testing if indicated, so if there is any clinical suspicion of myocardial injury, the doctor may decide to order an echocardiogram, a sonogram of the heart to look at the function, a cardiopulmonary exercise test, that's the VO2 max test I think everyone's familiar with, high sensitivity cardiac troponin, that's that blood test, and then a cardiac MRI if needed. So here in San Antonio, we made a post-COVID-19 clinic to do cardiac assessments for athletes that have been confirmed with COVID. So if you want more information about this, I'll have the email address where you can email. It'll come to me, I can call you and help you get scheduled with an appointment if you would like. But this is just to provide a resource to you guys if you're not sure if an athlete has any significant injury from COVID. Just get a sports cardiologist on board, help them determine when it's safe to return to play. So like I was saying, there's different algorithms proposed by American College of Cardiology. Different schools, different universities, different hospitals have different algorithms for who should have a cardiac screening and how return to play should go. So in San Antonio, we have decided we think it's reasonable to consider a cardiac evaluation for anyone that's tested positive for COVID. So if we go back here, that probably will just be an initial discussion with a cardiologist and then learning how to observe for symptoms. So we're not advocating for really high level of testing. We do not want to keep the athletes out of play for a long time. We know they need to get back to training, but we just want to make sure that they're doing it in a safe way. So the reason why we do advocate for at least a meeting with a cardiologist is because the high prevalence of myocarditis post-COVID, regardless of symptom severity. So there's a paper that I think was published in JAMA from Germany that went very popular. They looked at about 100 different people after COVID infection from all different ranges, from asymptomatic to hospitalized, and they found some evidence of myocardial injury in about 80% of these people. Granted, there are some limitations on this study. Some of these people were still symptomatic. It was not an athletic population. But even looking back at the Big Ten, they have 1/3 of their athletes have some evidence of myocardial contribution or injury from the virus. So we think it's worthwhile to at least ask a cardiologist what they think. Then also the extraordinary demands on the athlete's heart. So like I was saying at the beginning, these are not general population. We're going to be requiring a lot from their heart, so it's worthwhile to make sure that they don't have any evidence of myocarditis. And then again, lack of data, we just really don't know. And then the sports cardiologist can help with return to play guidelines. So if there is evidence of myocarditis, you know how to go about slow return to play, when you can start exercising again, and things like that. So the goal, safe return to play and careful observation so that the athletes' parents, the athletic trainers know what to look out for. And I can't advocate for this enough for the athletic trainers to just really be paying close attention to your athletes. So you guys know, I mean, you know your athletes, you know what their good days look like, you know what their off days look like, you know what it looks like when they're up all night studying and didn't get sleep. So you guys are really in tune, you know when something is wrong. So just really paying attention to your athletes, talking to them, is going to be one of the main ways we can help keep them safe. So goal, safe return to play, not unnecessary testing, delaying return to play, or medical disqualification. So in summary, the SARS-CoV-2 virus is well known to cause cardiac complications. This includes myocarditis. Myocarditis is especially concerning to athletes because it can be very dangerous during exercise with these arrhythmias. A sports cardiologist is an essential part of the athlete's interdisciplinary team, and data is very limited. Have an emergency preparedness plan and just pay attention to your athletes, and please reach out to a sports cardiologist if you do have any concerns about your athletes. So this is an email address that if you want to take a picture of this, sorry, it's kind of a wordy email address. If you have any questions or if you want to schedule one of your athletes to be seen by a sports cardiologist, just shoot an email to this account. I can call you and help you get scheduled. My personal email address is on the bottom, and then I'll open it up for any questions.